Today, we are on site at the San Diego Convention Center in California at the 2018 ASH annual meeting. We'll be recapping some of the top news presented each day during the meeting, and soon we'll speak with Dr. Ruben Mesa on the myeloproliferative neoplasm data, Dr. Pinkal Desai on the top acute myeloid leukemia abstracts, and Dr. C. Ola Landgren on the pivotal multiple myeloma studies. Welcome to OncLive News Network. I'm Gina Columbus. Results of the Phase 3 Transcend 004 study show that the chimeric antigen receptor T-cell therapy lisocabtagene maraleucel had manageable toxicity and encouraging clinical activity in heavily pretreated patients with chronic lymphocytic leukemia. Complete responses and undetectable minimal residual disease were achieved with liso-cel in both patients with high risk and standard risk disease who previously received ibrutinib. In acute myeloid leukemia, venetoclax combined with either azacitidine or decitabine led to high rates of rapid, deep, and durable responses in patients ineligible for standard induction chemotherapy. Additionally, the combination of venetoclax with low-dose cytarabine was also linked with encouraging responses in patients with AML who were ineligible for intensive chemotherapy. In multiple myeloma, the chimeric antigen receptor T-cell therapy BB21217 showed early signs of efficacy in relapsed refractory patients. Moreover, the safety profile was consistent with known toxicities of CAR T therapies. Longer follow-up and a larger number of patients will confirm whether BB21217 leads to sustained CAR T-cell persistence and responses. Findings from the randomized Phase 3 Augment trial showed that the combination of lenalidomide and rituximab improved progression-free survival versus rituximab plus placebo in previously treated patients with relapsed refractory grade 1 to 3A follicular lymphoma and marginal zone lymphoma. Overall response rate, complete response, duration of response, and time to next anti-lymphoma treatment were also met with R-squared. Fewer deaths also occurred with the combination. In multiple myeloma, findings of the Phase 3 Tourmaline MM1 trial showed that weekly maintenance treatment with ixazomib demonstrated a reduction in the risk of progression or death in patients with newly diagnosed patients who had at least a partial response to induction therapy with a proteasome inhibitor and/or an immunomodulatory drug followed by single ASCT. Ixazomib led to deep responses, increased conversions to minimal residual negativity over control, and a manageable safety profile. Patients on the maintenance treatment had an absence of risk of second primary malignancies and low rates of peripheral neuropathy. Here now to expand on some of the myeloproliferative neoplasm abstracts being presented at this year's meeting is Dr. Ruben Mesa, who's the director of UT Health San Antonio MD Anderson Cancer Center. Hi, Dr. Mesa. Thank you so much for being here.
Hello. No, excited to be here.
Great. So there are, of course, a ton of abstracts being presented at this year's meeting. So which ones in the MPN space are you particularly excited about?
Well, it's a very exciting time for MPN research. So one, I think there's important information this year in not one but several abstracts, really how we look at the molecular mutations and their relevance in terms of disease biology, progression, and targets for patients with MPNs. So very recently there was a New England Journal of Medicine article that came out from Cambridge and trying to digest all of that. So that's really key. Second, just the sheer volume and activity of the clinical trials being conducted for these patients, particularly in myelofibrosis, where we really have very exciting both single agent and combination studies.
Good, great. So we're also learning about the results of the Myeloproliferative Neoplasms Research Consortium trial of pegylated interferon alpha 2A versus hydroxyurea in high-risk polycythemia vera or high-risk essential thrombocytopenia. Could you highlight the importance of this trial?
Sure. Well, for patients with polycythemia vera and essential thrombocythemia, there still remains an open question as to what is the optimal frontline therapy. And there's controversy that still exists in our field. Should that be hydroxyurea or should that be some form of long-acting interferon? The MPN Research Consortium is a NCI-funded program project grant. This is a cooperative group led by my colleague Ron Hoffman, of which I am a proud member. This was a large Phase 3, it was an investigator-initiated study, and the first to really look at this in the frontline setting. What my colleague John Mascarenhas presented this meeting is really the kind of accumulation of that data, the summary of that trial. One, both drugs are very active. We were not clearly able to demonstrate that pegylated interferon was superior to hydroxyurea, but nor was it inferior. So I'd say it was non-inferior, which is an important observation in and of itself. It's an important therapy. We present the molecular findings representing activity against the molecular mutations associated with the disease. I present in parallel with that an abstract with a deep dive related to the symptomatic improvements, where we see good symptomatic improvement with both therapies, some differences between them, but good activity in both, some low-grade toxicities that are from a symptom perspective with patients on the pegylated interferon alpha arm. So again, an important study helps to validate interferon as a safe therapy, as effective in decreasing events, at least as beneficial as hydroxyurea, an important weapon that we can use for individuals that are facing that disease.
Very interesting, great.
Yeah.
Now, we're also seeing a 156-week follow-up of the phase 3 response 2 trial in polycythemia vera. So what is new to report with this trial?
So for ruxolitinib and polycythemia vera, there have been two key studies. There was response that had required, in addition to failing hydroxyurea and difficult disease, splenomegaly. Now, Response 2 was a trial that was created in part to recognize that not all patients with difficult PV have splenomegaly. So is it as safe and effective for this group, which probably represents a broader swath of patients with PV? What my colleagues were able to demonstrate and present was that indeed it really has performed very well. Durable responses, effective against symptoms, phlebotomy independence, no long-term safety signal. We had presented in parallel the 5-year data from Response. So what we see is that both Response and Response 2, very safe, very effective, and that splenomegaly, if it's there, it will respond, but it really is not necessary to achieve a response.
Okay, all right. So now let's talk more about some of the other JAK1/2 inhibitors. So are there any other kind of new data that we're looking at with ruxolitinib, fedratinib, momelotinib, or pacritinib?
Well, great. Well, the JAK inhibitor space continues to be very active for MPNs. Rux is approved in MF and PV and really has become the standard of care in frontline MF and second line for PV. We really have 3 with parts of data both being presented at this meeting but also very active at the moment in parallel with ASH. First, I would say, is pacritinib, that is in an active trial trying to find the minimally effective dose in a drug that's already proven its significant activity for splenomegaly and symptoms in patients both with marked thrombocytopenia as well as those without, in patients with myelofibrosis. So that PAC-203 study is almost done with accrual, and we're hopeful that that might become an agent that will be available for patients with difficult MF in the near future. Second, there is fedratinib, recently acquired by Celgene. This is an agent that already had a successful phase 3 study, Jakarta, versus placebo improving splenomegaly and symptoms. A successful phase 2 study in a second line setting. It was shelved for many years after a clinical hold over a concern of neurologic toxicity. Deep analysis of those patients showed that risk was very modest and the clinical hold was lifted. There are efforts now underway with Celgene as the holder of that drug to try to find a regulatory path, and there has been a trial that has been announced that will be accruing soon to support a fedratinib registration to, let's say, complement the data that has already been gathered from the past. Third, there is momelotinib, that it had a successful phase 3 study that I presented at ASCO a couple years back that was published at JCO, as well as a second line study. That drug was in Gilead's hand. Now it has been picked up by Sierra Oncology, and there are efforts underway to find potentially a path for a momelotinib as well. So I'm highly hopeful, as I share with patients, that we may have one, if not more than one, additional JAK1 or JAK2 inhibitor available in the near future for them.
Great, that's very exciting. Now, what other targets are we looking at besides JAK? How about any others that are of interest, and are there abstracts exploring them at this meeting?
Correct. So there are many that I would highlight. One, there are both ruxolitinib combination studies, ranging from Rux with pegylated interferon, or thalidomide, or decitabine, or azacitidine, all of which were positive, all of which were intriguing and being presented. There's Rux with a PI3 kinase inhibitor. Both there's been ones from TG as well as from Insight, both of which have been active. There are single agent studies both with the antifibrosing agent from Prometeor as well as imetelstat from Janssen, both of which are positive, both being reported as single agent. So a lot of things that really are active in this difficult group. Obviously, what is the next step for those? What is sufficiently active to either try to seek an indication or be used off-label? We know hypomethylating agents are available. They're already being used in some amount now. I would say that the data from this meeting will further impact practice, whether a additional indication is really achieved or not. Thalidomide falls in that same category. Pegylated interferon can be prescribed off-label. So there's a range of off-label implications as a less common disease, but some of these other investigational agents may well have a path in the near future.
Great. Well, Dr. Mesa, thank you so much for sitting down with us today and talking about all of these data.
Well, great. No, a pleasure being here. Thank you.
Thank you. Next up, we have Dr. Pinkle Desai, who is an assistant professor of medicine at Weill Cornell Medical College and an assistant attending physician at New York Presbyterian Hospital, to discuss the recent advancements in the treatment for patients with acute myeloid leukemia. Hi, Dr. Desai. We're so happy to have you here today.
Same here. Very excited.
Great. So, 2018 has been such a progressive year for AML treatment. What are some of the advancements that have happened just over the last couple of weeks that you can mention?
So we have obviously 3 new drug approvals in the last 2 weeks. We have venetoclax, glasdegib, and gilteritinib, all approved just in the last 2 weeks. It's been whirlwind, actually. As we know, venetoclax and glasdegib has been approved for frontline treatment of AML. Venetoclax is approved for combination with hypomethylating agents and low-dose cytarabine, and glasdegib has been approved in combination with low-dose cytarabine. Obviously, gilteritinib is now approved for FLT3 mutated AML in the relapsed setting. And these were very important trials that we've been waiting responses for a while. And it's changing the patterns of practice in AML we've not changed the practice of AML in such a long time. This is high time.
Definitely.
Yeah.
Now, going into the frontline venetoclax approval, which patients is this best suited for? And obviously, if you could also maybe talk about the venetoclax data that we're seeing here at this year's meeting.
Sure. So the venetoclax trials were done in patients who were either over 75 years of age, or they were older, 60 to 75, and were considered unfit for induction chemotherapy. So these were all the patients who were enrolled into the trial. So this is where the drug is approved for and has an indication for. And the data has been very promising, because if you look at the data that was just presented at ASH for the hypomethylating agent backbone with both Vidasa and decitabine, the responses have been approximately 70%. So if you compare it with single agent historical data for hypomethylating agents, it has ranged from between 20 to 40%. So this is substantially improving the CR rate. And I think what is actually important also is that the venetoclax seems to be a mutation agnostic drug. So some of the mutations that we consider high risk that don't show response have also shown responses. I think the data we just saw at ASH that about 60% of TP53 mutations are responding to it frontline, and over 90% of the IDH mutations. So it's nice to have a drug that is kind of mutation agnostic.
Definitely. Now, we're also seeing data from the Quantum R study looking at quizartinib in FLT3 ITD positive AML. So could you discuss these data?
So these were also long-awaited results. This was a randomized phase 3 study of over 350 patients of AML. Quizartinib was randomized to what we considered investigator choice or standard treatment. That was a mix of lower intensity treatments and high intensity chemotherapy, and the overall composite complete response rate was seen in 48% of patients with quizartinib versus like 26% on the control arm. So I think that this is also exciting data coming out.
Definitely. Now, there are also first-in-human results with a CD33 targeted by antibody construct in relapsed refractory patients. So what is exactly the mechanism of action of this drug, and what do we know thus far about the results?
So this is in the category of immunotherapy. So as we know that bispecific antibodies, or BiTEs we call them, are big in ALL. So acute lymphoblastic leukemia has an approved BiTE, which is blinatumomab, and a similar concept is being now used in AML. So they have a unique mechanism of action in the sense that the drug is an antibody that basically binds CD33 positive cells, which is basically over 99% of AML, and also the body's native T cells via the CD3 receptor, and the idea being that you harness cell kill by bringing these two cells together, and so that the T cells destroy the leukemia cells. So this is a interesting mechanism of action, already proven to be effective in ALL and now being explored in AML. And we saw the first in human results. There were 35 patients treated. And we see a cytokine release syndrome, what is expected out of these kind of drugs, but easily treated with steroids and tocilizumab. And interestingly, there were 2 complete remissions seen so far, and 2 incomplete remissions seen. So I think with more cohorts and higher doses, it would be important to see how many patients can go into remission, and more importantly, sustain those complete remissions.
It sounds very interesting.
Yep.
Great. Now, are there any other abstracts this year in either AML or even myelodysplastic syndromes that you would like to mention?
The big one is luspatercept in MDS. So with AML having a record number of drug approvals, MDS should not hopefully be left behind. So we saw data on the phase 3 study of luspatercept, which is in the family of drugs that counteract TGF-beta ligands. And the idea of the drug is that it improves transfusions in lower risk MDS. So we saw that patients that were lower risk, like low, very low, and intermediate risk, when they were given luspatercept, about 40% of patients achieved transfusion independence and maintained it for a year, which in the lower risk category, we really don't have a lot of drugs to improve transfusions. Once the erythropoietin stimulating agents stop working, there's really nothing to use. So I think that this is an exciting drug, and hopefully we'll see some good news going forward.
Yes. Now, where do you see research going next in AML, and with the number of drugs that are quickly becoming more and more available, is this also affecting any kind of sequencing decisions or considerations that you have?
So I think from a sequencing standpoint, most big centers are already sequencing patients with AML, and I think that should be the standard of care. There's a lot of targeted treatments coming up, so I think that there's a standard set of sequencing data that we're getting on all of these patients. I think it'll be more and more important to get them soon, because you have several of these inhibitors out there, and until you get the full panel back, you really don't know what you want to use. So I think the faster getting these tests faster would be very, very helpful. And from a standpoint of future of where this is go, we are in a very unique situation where we have several drugs that are approved. So what would be interesting going forward is how can we combine them in the best possible way so that we can improve overall survival. And if any of these agents are better at achieving deeper responses and less of measurable residual disease, I think that's what we have to look forward to.
Absolutely.
Yeah.
Dr. Desai, thank you so much for sitting down with us today.
My
you
pleasure.
gave some great insight. We really appreciate it.
Thank you.
Thanks. Finally, we are joined by Dr. C. Ola Landgren, who is Chief of Myeloma Service at Memorial Sloan Kettering Cancer Center. Hi, Dr. Landgren. We're so happy to have you here today.
Thank you so much for having me.
Great. So, The MAIA study, which is looking at frontline daratumumab with lenalidomide and dexamethasone in patients who are ineligible for transplant, is an eagerly anticipated abstract this weekend. So this is a late breaker abstract, but what can you tell us about the study design and why this trial is important?
The presentation will take place here on Tuesday morning, so we are not allowed to give the details of it, but we know that there is a highly significant superiority for the 3-drug combination. So daratumumab in combination with lenalidomide dexamethasone is highly significantly better for progression-free survival compared to the Revlimid dexamethasone. I think it's going to be a very exciting study, and I actually think the study potentially could introduce a new standard of care for patients that present with a new diagnosis of multiple myeloma. For a long time, the VOD regimen with bortezomib with lenalidomide dexamethasone has been the favorite in many centers. Now we have another option. We have also the KOD regimen, the carfilzomib lenalidomide dexamethasone. Again, we have a new option here. I think that could be uptake for many patients in different places with this new regimen.
Yeah, that's a great point. Now, part 2 of the phase 3 STORM study is looking at selinexor with low-dose dexamethasone in penta-refractory multiple myeloma. So could you discuss selinexor and how these findings are impacting the patient population?
Selinexor is a drug of a unique class. It's a protein transport inhibitor that blocks the influx, outflux of certain proteins in the nucleus of the tumor cells. So the cells basically get clogged with bad proteins in the nucleus that they don't like, so that's why they die. The study here showed that the selinexor in combination with low-dose steroid, dexamethasone, results in a response in patients that are heavily pretreated, patients who have failed all the other FDA-approved combinations. You still see about a quarter of the patients are responding. The duration of the response in this quite heavily pretreated population is about 4 months. So that's the duration of the response. Also, there are toxicities that have been seen with selinexor. It's been reported at other meetings as well. It involves the gastrointestinal toxicities with diarrhea. There is nausea involved. Patients have fatigue and asthenia. So I think there is a little bit more work, I think, to be done, and there is actually ongoing work that we anticipate to see here in a couple of months at coming meetings and in coming reports in combination with other drugs. Velcade dexamethasone with selinexor, pomalidomide dexamethasone with selinexor, Revlimid dexamethasone with selinexor, daratumumab with selinexor. So we have the whole alphabet soup here with selinexor, and peculiarly the toxicities I was mentioning seem to be actually slightly lower when you have these other drugs in combination. So I think the story is to be continued.
Very interesting. Okay. Now, there's the quadruplet regimen of daratumumab, bortezomib, lenalidomide, and dexamethasone, which is being explored in the Griffin study. So what's important to note about this trial?
So 3 drugs, 4 drugs, how many drugs shall you give? So the standard of care for newly diagnosed patients with myeloma is 3 drugs. I talked about the VOD regimen with bortezomib, lenalidomide, dexamethasone being probably the most commonly used in private practice. Then I also talked about the KOD regimen with carfilzomib, lenalidomide, dexamethasone. There is more uptake in the academic centers. We use this as our default. I think that's a more powerful regimen than the VOD regimen. I actually give a talk here tomorrow from the COMPASS study, where we have done a nested case control study within the COMPASS study showing that there is superiority for the KOD regimen. That's actually quite profound for event-free survival. So what about these 4 drugs? So you mentioned the VOD with daratumumab. So the Griffin study will be presented here at a meeting by Peter Voorhus, showing that if you add daratumumab, you also have better, deeper responses, and you have better progression-free survival. I think it's important to also emphasize that it's very early, so the Griffin study has not yet kind of read out its primary endpoint, so they enrolled all the patients, but the data is very early. We also have a presentation ourselves here where we use the KOD regimen with daratumumab. So I give a presentation here today at the poster session where I show up to 80% MRD negativity with this KOD regimen with daratumumab, and this is without transplant. So this is very, very strong. Early on, small numbers. We need to have more patients followed longer, but it looks very promising. I think 4 drugs is going to become the new standard of care for patients who are in good shape, who are fit, And then the question is, do you need to transplant all of them? I'm not sure that that needs to happen, but that's certainly controversial, so to be continued.
So I'm really glad that you mentioned this other presentation that you're a part of. Would you like to expand a little bit more on it?
Yeah, so from this poster presentation that I have here today, we show the 4-drug combination with daratumumab with the KOD, or carfilzomib, lenalidomide, dexamethasone. I mentioned the high rates of MRD negativity, 60 to 80% in that range, which is quite strong data. So beyond just like the traditional workup and including the bone marrow MRD, we also have now started showing data that we have worked on for a while, blood-based MRD testing. We have worked for about 10 years in the laboratory trying to figure out how can we use blood-based testing to be the new way of doing MRD, because much better for patients. You don't have to do biopsies. You can actually do it much more often. You could technically do it every time you do blood draw. So I think circulating DNA is not going to be the path forward, because there is too little tumor DNA to be used reliably to rule out MRD in the blood. You need so much blood, so it's just not practical. I also think the circulating tumor cells in the blood are too few to reliably be used, so there will be a lot of false negative. So instead what we have done, and that's what we present here, is that we use mass spec-based technology. So we are looking for very, very low levels of proteins that have been made by very small number of cells. So we now have technologies that are probably 1,000 times more sensitive than anything that we used to have before. They are pretty much correlated in terms of sensitivity, it seems, to about the level of what flow cytometry can do in the bone marrow.
Okay.
So that's very interesting. So what we are trying to do now is to see how we can look at the slopes of these proteins and longitudinally follow and see if these potentially could either replace or complement the monitoring for patients treated with these new modern therapies. So I'm very excited about that.
Yes, it does. It sounds very exciting.
Yeah.
Great. Now, moving on to ixazomib. So maintenance treatment with this agent is being addressed in the Tourmaline MM3 trial in newly diagnosed patients after transplant. So what are your thoughts on this study and the findings?
Ixazomib, that's one of the new drugs. We have so many new drugs here. So ixazomib is FDA approved for the indication of recurrent myeloma in combination with Revlimid dexamethasone. People have wondered, could this be a new maintenance drug? So the trial you're referring to is a randomized study that reads out. So the control arm is placebo. So you compare the ixazomib to no drug, and then they show in this presentation that there is a superiority. It was presented by Thanos Dimopoulos from Greece. He also showed that the duration, the benefits with the addition of ixazomib is about 4 months. So I think if you look at the duration of Revlimid compared to nothing, it's less with ixazomib. So I think the clinical message here is that probably ixazomib could not replace Revlimid. But I also think it's important to emphasize that there are many patients who go on Revlimid maintenance who cannot really tolerate it.
Right.
They can have gastrointestinal symptoms, diarrhea. Many patients can develop fatigue. They cannot really function, and there could be other issues as well. So I think it's just another option, and I think that's how the field seems to keep on evolving. There's just another option, another option, another option. So looking for these phase 3 trials that show survival benefits and head-to-head, that seems to not really be the direction where the field is going. It's just going to be a lot of new drugs approved, and I think the doctors have to use their judgment and talk to the patients about all these different options, and different doctors, different patients will have different opinions. So it's becoming more complicated. That's kind of the side effect of all the advances we have seen with all these new drugs.
And I'm really glad that you ended with that, because I really want to get in your head and talk about, where do you see the myeloma landscape going a year from now? What does it look like to you?
So it's obviously impossible to know, so I will have to kind of put my guessing hat on, so do some kind of a best guesstimate here. I do think that the antibodies moving up front is definitely going to change the game plan. I think the uptake from Maya can be quite big. So the Maya study with daratumumab, with lenalidomide, dexamethasone, I think it's a great option for many patients. You don't have the neuropathy that you see with Velcade. You can deepen the responses. It's very well tolerated. That also introduces a new maintenance along the lines of what we discussed before with the Acilon trial, when they stopped the Velcade melphalan prednisone after 9 cycles and continued just with daratumumab. So daratumumab could also become a new maintenance actually, so that here we have a third option.
Right.
Although that was not really how it was developed for the purpose of the trial, but it kind of ended up being like that. So I think the antibodies will move up early on, and that could also lead them into the extension of this. And then we talked about the Griffin study, and we talked about the Sloan Kettering study with daratumumab in combination with KRD. So I think the field will slowly migrate into a direction where you could have antibodies up front, maybe with lenalidomide dexamethasone, or you could have the 4-drug combinations with amazing MOD results that really is going to continue to deepen and prolong the duration. And then I think the MOD testing will have a very important role, because I think that that could also lead to MOD-driven decisions. So could you maybe collect stem cells and not transplant patients? That's what we already are doing at Sloan Kettering. Could you use that if patients, God forbid, were to have a recurrence early on with conversion back to MOD positivity? Could that in the future trigger retreatment? That's not in the guidelines, so don't try this at home yet. So I think those are things that gradually are going to come into the new game plan. So a lot of change and many new drugs are coming. We did not talk about the bispecific BCMA antibodies. They're spectacular. We didn't talk about the CAR T cells, also amazing results. And there are a lot of other small molecules you have beyond the venetoclax. You have also MCL1 inhibitors. Could you have a BCL2 inhibitor with an MCL1 inhibitor? From a rational standpoint in the lab, that makes very good sense, and there is preclinical data showing that that is really amazing. So where all these things are going to go, and where do they fit, and so many questions we don't know the answer to.
But there's a lot going on, so it sounds very exciting.
Very much going on.
Great. Well, Dr. Landgren, thank you so much for being here today. We had a great time talking with you.
Thank you for having me.
Thanks. That's all for today. Stay tuned for tomorrow's OncLive News Network On Location, where we will sit down with Dr. Brad Call of Washington University School of Medicine in St. Louis to highlight the recent findings in non-Hodgkin lymphoma, Dr. William Weirda of the University of Texas MD Anderson Cancer Center to share insight on chronic lymphocytic leukemia abstracts, and Dr. Owen O'Connor of Columbia University Medical Center on some of the mantle cell lymphoma and T-cell lymphoma trials. Thank you for watching OncLive News Network. I'm Gina Columbus.